Hello and welcome. My name is Donna Cryer. I am the founder and CEO of the Global Liver Institute, and I have a very special episode of this International NASH Day series for you. This panel, this edition, is hosted by the Association of Black Gastroenterologists and Hepatologists, and is in partnership with that August organization that I hope many of you will, if you haven't heard of them before, will recognize their expertise today and go on to work with them throughout the year and moving forward on NASH and other liver issues. Our theme this year is NASH around the world, and we are using the hashtag NASH Day. So please follow along on social media with that hashtag. Next slide. In addition to the Association of Black Gastroenterologists and Hepatologists, we are so honored that over 17 medical societies around the world have come together to support the Global Liver Institute and International NASH Day. A special shout out to AASLD and to EASL. And so this conversation on NASH, a conversation in the Black community, I have the honor of introducing the inaugural president of the Association of Black Gastroenterologists and Hepatologists, Dr. Balzora. I turn this over to you for the first time ever. Thank you.
Thank you so much. I really appreciate that. Hello, everyone, and thank you again for tuning in. My name is Dr. Sophie Balzora. I'm a clinical professor of medicine, clinical associate professor of medicine at NYU Grossman School of Medicine, and a gastroenterologist at NYU Langone Health. I am also the president of ABGH, or the Association of Black Gastroenterologists and Hepatologists. I want to start by thanking the Global Liver Institute for this sponsorship with ABGH. Next slide, please. So here's some housekeeping and where to find us, and just going into what ABGH is all about. Let me tell you that the mission of ABGH is to promote health equity in Black communities, advance science, and develop the careers of Black gastroenterologists, hepatologists, and scientists. So going deeper into that, when we think about the vision of ABGH, we have 4 pillars. One is to improve gastrointestinal health outcomes in Black communities, develop the pipeline of Black gastroenterologists and hepatologists, foster networking and sponsorship among Black students, trainees, gastroenterologists, and hepatologists, and finally, to promote the scholarship of Black gastroenterologists and hepatologists. Next slide, please. So now, allow me to introduce Dr. Rotonya Carr. Dr. Rotonya Carr is an associate professor of medicine in the Division of Gastroenterology at the Perelman School of Medicine at the University of Pennsylvania. Dr. Carr is an NIH-funded basic science researcher who studies fatty liver biology and a clinical hepatologist who founded and directs Penn's Liver Metabolism and Fatty Liver program. Dr. Carr is a founding board member of the Association of Black Gastroenterologists and Hepatologists and a member of the American Gastroenterological Association, or the AGA, the American Association for the Study of Liver Diseases, or AASLD, the European Association for the Study of the Liver, and Research Society of Alcoholism. Rotonya, I'll pass it over to you. Thank you.
Thank you so much, Dr. Balzora. We at ABGH are honored to have you at the helm as our leader. And I am so excited to be here with all of you today to bring awareness to NAFLD, non-alcoholic fatty liver disease, and NASH, non-alcoholic steatohepatitis. What we especially wish to highlight today is that NAFLD is a disease that impacts predominantly minorities. And while it is most prevalent in the Hispanic community and Latino community, the stories of Black individuals with NAFLD are often less appreciated. We also wanted to increase awareness about these groups by encouraging Black hepatologists to engage in this conversation. Now, before I introduce our guests, let's just make sure that we are all on the same page about what we mean when we say NAFLD and NASH. Next slide. So as I said, NAFLD stands for non-alcoholic fatty liver disease, and NASH stands for non-alcoholic steatohepatitis. The liver normally has some fat within it, but usually only 5% or less of the liver has fat. So when we diagnose someone with a fatty liver, it means that they have more than that 5%, and oftentimes at least 30% if we can detect it on radiology. Patients with a fatty liver can develop NASH, which is that stage of liver disease that causes liver inflammation. The liver can swell, the liver can scar, which we call fibrosis. Patients can develop cirrhosis, where the liver becomes lumpy and bumpy and has trouble doing all of its jobs. And even sometimes patients can develop liver cancer. Next slide. What we want to impress upon our viewers today is that this is a very common disease, worldwide, in fact. And here in the US, where we are, a third of all US adults are estimated to have this condition. And 1 in 10 kids has it as well, which is very concerning, of course. There are several risk factors. Obesity, diabetes, or borderline diabetes, high cholesterol, high blood pressure are the most common. But there are others like family history and genetics. And importantly, we want to highlight today that 40% of Hispanic and Latino individuals have NAFLD, and 20% of Black and African American individuals have NAFLD. And it is this latter category that we want to really amplify today during this session. Next slide. So I now have the privilege of introducing 2 of our panelists whom you have not gotten a chance to meet yet today. The first is Dr. Lorna Dove. Dr. Lorna Dove is a professor of medicine and surgery and the medical director of liver transplant at Columbia University Medical Center in New York. She joined the New York Presbyterian transplant team in 2001. Her clinical and research interests include liver transplant outcomes and improvement in care systems for those underserved by the medical system. Dr. Dove is an inaugural member of the Association of Black Gastroenterologists and Hepatologists and a member of the American Association for the Study of Liver Diseases. We welcome her today. Our next panelist, whom you've not gotten to see today, is a patient, and she happens to be a patient of mine, Ms. Denito Myers. Ms. Denito L. Myers is a resident of South Philadelphia and a mother of 2 wonderful children. She obtained her master's degree in operational leadership and management from Pierce College and is currently the Chief Revenue Cycle Manager at Quality Community Health Incorporated. Ms. Myers is very active in various educational and community service programs, including at Solid Rock Baptist Church, where she directs the youth adult choir, is the assistant director for the music ministry, and participates in dance as well as in community outreach. We welcome her. Joining this panel too will be someone whose face you've already gotten to know, Ms. Donna Cryer, and she is the founder and CEO of Global Liver Institute. She's had a liver transplant, and she will bring forward that perspective as well later in the session. So I would like to start the conversation with Ms. Myers. Ms. Myers, we've gotten to know each other only recently, and you are newly diagnosed with fatty liver disease. So I think your perspective is really very critical here today. And before we get into how you were diagnosed with having a fatty liver, I want you to tell our viewers here today a little bit about your health before you came to know that you had fatty liver disease. Ms. Myers, we're going to need to take you off of mute. Thank you. Can you start again?
Yes.
It's okay.
Thank you, Dr. Carr. Prior to learning about my fatty liver disease, I was a person that went to the doctors as suggested yearly checkups, and my doctor always said that my numbers were healthy. Just obesity, I needed to lose weight. It never was any problems with chronic illnesses, as high blood pressure and diabetes or anything. Recently, I was diagnosed with pre-diabetes, but other than that, I was pretty healthy. Just losing weight was the problem.
Yeah. And so it sounds like you were doing fine, feeling fine, working
Yes.
on your weight. So how did this diagnosis of fatty liver come about? Tell us about that.
Well, the discussion of why I wasn't losing weight, because I eat, healthy, I take walks, and my doctor said that my liver, she wanted to do an ultrasound for my liver. And I went to Dr. Carr, and she explained that I had the fatty liver disease, and I learned more about it.
Were you having pain or symptoms?
No pain at all, no symptoms. And as till today, I still don't have any pain or symptoms.
And so when your primary care doctor told you that she was concerned about you having a fatty liver, how were you feeling at that time? What were your thoughts?
Well, my first thought was to run to Google, which I don't suggest. That was my first thought. And I panicked. I panicked and ran to Google, and I looked it up, and I was afraid because I had never, heard of the fatty liver disease. I'm a person that never drank and never smoked and always seemed pretty healthy. No pain, like I said, and no symptoms. So I was panicked and I was stressed because I didn't know what to expect.
Yeah. And Dr. Dove, I want to bring you in here now. So Ms. Myers has explained that she was, doing fairly well, working on her weight, wasn't having any symptoms, really no pain. And her doctor decided to run some liver tests, found some abnormalities, got an ultrasound, and showed a fatty liver. Tell me, in your experience, Dr. Dove, how common a presentation this is.
First off, thank you for inviting me to be on the panel. I would say that this is by far the most common presentation. When you're talking about a third of the population having fatty liver, a third of the population's not feeling sick. So most people, when they find out they have fatty liver, have absolutely no idea. I think what we find the beauty of the liver is the liver has this ability to repair itself and regenerate itself. And so when it's injured by anything, it begins this reparative process. And sort of the beauty and the curse is it's repairing and keeping you healthy. But the curse is that means that a lot of liver disease, fatty liver disease, and many other liver diseases are silent. And people will have no idea something is happening to them unless their primary care provider on routine labs notes the liver tests are a little elevated, or they get some type of ultrasound or abdominal imaging, sometimes for a totally different reason, and someone notes that their liver looks abnormal. So I think that Ms. Myers' story is one I hear all the time.
Do you think that most providers are thinking of this as a diagnosis, or are they having challenges making this diagnosis or maybe managing it once they've diagnosed a person with fatty liver?
I think that there has been a lot more awareness about fatty liver in the last 5 to 10 years. I think prior to that, we saw fatty liver as a completely benign process not to worry about. And over time, we've realized that there is a significant number of people who really have problems long-term from fatty liver. And so we have begun the education process, though probably not as quickly as we should. And so I think a lot of providers, primary care and other specialists, and specialists in diabetes or heart specialists are very aware of fatty liver disease. I think where we need to do a lot more is we need to educate people and patients so that they know that they have the risk factors for fatty liver disease, so they know to be proactive about their own care, ask their own providers, do you think I should be screened for fatty liver disease? And you mentioned in your slide the risk factors. So if you are diabetic or borderline diabetic, or you have high cholesterol, or your doctor is telling you that your weight is higher than it should be and you need to lose weight, or you even have hypertension, all of those things are risk for having fatty liver, or you have a family member who has fatty liver, then the patient is a part of the process and will advocate for themselves. And I think that that's where we've sort of fallen behind on, the education portion.
Yeah, I definitely agree with you. This conversation is so important. We're so appreciative to our panelists today for helping us just spread the word. And this International NASH Day is really designed just to do that. Dr. Dove, you talked a little bit about getting checked or getting screened. So if someone were to be concerned about this, or a provider, is concerned about it for his or her patient, what would you recommend as kind of the first step to look into this?
I think the first step is to look at all the risk factors. And I think that make sure that you've had someone check your glucose, make sure that your blood pressure, make sure your cholesterol, make sure that someone is paying attention to your weight and your nutrition. And then the next step is, what do you do when you actually see the provider? And often part of the routine lab screening are tests that look at your liver enzymes, that look to see if the liver is inflamed. Unfortunately, because of what we talked about before, the liver sometimes repairing itself, those tests could be normal and not tell you the whole story. And so if you really have those risk factors, stopping with the blood test may not be enough. And that's when, like, your doctor sent you for an ultrasound, which can show that there's fat in the liver. A number of imaging tests, CAT scans, MRIs, depends on the person. That's something you have to discuss with your doctor. There's a new FibroScan that looks actually at how much fat's in the liver. And all those things are possibilities sort of depending on the person. But those are the types of things that patients should explore if they think that they have fatty liver or they're at risk for fatty liver.
Thank you for that. So really, in a nutshell, it's really individualized. So you have to, as a patient or a family member, someone who you think might be at risk, be an advocate and have those conversations with your provider so that you and your provider can determine the next best steps to figure this out. So going back to you, Ms. Myers, you said that you were given the diagnosis of having a fatty liver by your primary care provider, and then you came to Hepatology Clinic, to my clinic. I'd like you to tell our viewers what that visit to hepatology was like. A lot of people are scared to go to the liver doctor. And how was it by the end of your visit? And you can say whatever you like. It's fine.
Well, let me start and say, Dr. Carr, you were wonderful, because I did come in, I was nervous. My blood pressure was raised. And by the end of the visit, I was calm. I knew more about the fatty liver. You explained everything great. You explained it to me. I understood it, and I knew what I needed to do to go forward. And not only that, you took time with me. You made me comfortable, and I thank you for that. It was a lot of information that you gave me, and I appreciate it, because sometimes you go to the doctors and they tell you things and they don't take the time to inform you of everything. So I came there, my blood pressure was raised, and I left, and I'm sure it was down. I was comfortable, and I appreciate it.
So tell us a little bit about, your takeaways from how you decided you were going to be able to take charge of your disease, and what have you done, and what effects have you noticed since then?
Well, the takeaway was that you did explain that we could get ahead of it by losing weight. Since then, I lost 16 pounds and my A1C has dropped. So I'm on track to reducing that fatty liver. And I'll continue to exercise, as you say, and eating the things that I should eat, cutting out things that I shouldn't have, and staying on track to continue to lose weight to reduce the fat in my liver.
Yeah, because it's, we find it early enough. It's a completely reversible condition. So that's really the message we want to convey as well today. Dr. Dove, so Ms. Myers talked about losing weight, changing her diet. And she and I certainly had conversations about what that would look like for her, because it pretty much is individualized as well. But in your own practice, if you can generalize for our viewers today, what is the general guidance you give for people who have a diagnosis of fatty liver, and what they need to specifically do to reverse their disease?
So I think that the challenge we have with fatty liver right now, unlike many medical illnesses, we don't have like a pill to fix that or a shot to fix that. It's really attacking all these separate issues that are contributing to the fatty liver. So there's something about diabetes or high cholesterol, hypertension that change an individual's metabolism and cause them to sort of deposit fat in their liver. And so you have to attack each of these individual issues to change that process. And Ms. Myers is the ideal patient. And I don't want to minimize that, because that is difficult. I mean, and in many ways, what you're doing is more difficult than taking a pill every day. People want something they can do easy like that. So what do we recommend? We recommend good nutrition, keeping your glucose down, keeping that hemoglobin A1C at 6 or less. We recommend having the cholesterol addressed. Sometimes that's just diet. Sometimes that requires a medication to help with that as well. You discuss that with your provider. We talk about exercise, and exercising maybe 3 times a week, at least 15 minutes, seems to help even in people who don't lose weight. And then losing weight, and our target is, 10% of whatever your weight is now, assuming that you're overweight, may help. So those are the sort of general guidelines that we give people who have fatty liver to help with the fatty liver. And then obviously you also want to expand keeping your liver in all other types of ways, because you already have one process. So you want to limit any other insult to your liver. So that often means we're recommending getting vaccinated for hepatitis A or B to protect yourself. We're recommending minimizing alcohol to protect your liver. We're recommending you tell any medical provider who's prescribing you a medicine, I have underlying liver disease, and you have to think about that when you prescribe. I mean, all of those are the types of advice that we're giving patients right now. Will that advice be different 10 years from now? Very likely. We may have more. I mean, this advice is just really good, healthy living advice. It's the same advice that cardiologists have been giving people for 20 years to protect their hearts, to keep their blood pressure down, to prevent strokes. So it's good advice, but now we are targeting patients who have fatty liver disease as well.
I'm glad that you brought up alcohol, because that's always the elephant in the room, so to speak. People are surprised that they could get liver disease and even get cirrhosis, which, as we said, is the advanced form of liver disease, when they don't drink a lot of alcohol. And the second thing I wanted you to elaborate on is, is there a safe level of alcohol for people who have fatty liver disease, and how do you negotiate that in your own practice?
So just two separate things. I think that cirrhosis point is worth, really reiterating. People in their mind associate cirrhosis with alcohol when cirrhosis really has nothing to do with alcohol. Cirrhosis is just a description of that scarred liver. The liver's been repairing itself, and regardless of what the liver disease was from, whether it was alcohol or hepatitis or fatty liver, some people will start this process where they develop this scarring. And then when the scarring becomes very extensive, that's cirrhosis. So we need to get rid of that stigma around having cirrhosis, is the first thing. As far as safe alcohol is concerned, that's a very individual issue in general. For women, 1 drink or less per day or 7 drinks per week is considered sort of in the safe range. For men, 2 drinks a day or less than 14 in the week is considered in the safe range. But again, that's very individualized. Some people, the number should be 0, right? If they have issues with alcohol overuse, and one will lead to many. Some people who already have advanced liver disease, I say, why do you want to live on the edge? Why don't we limit it to a special occasion or a wedding or, New Year's Eve, a glass of champagne. So I think that that's a conversation you have to have with your provider. You want to definitely stay low in that safer range, but for some it will mean none.
Thank you for that. Ms. Myers, we're going to come back to you in a little bit. I wanted to take a little bit of a shift now. We've been talking a bit about advanced stages of liver disease. Cirrhosis is a term we've been talking about, and sometimes people will need the care of physicians like Dr. Dove and other providers in transplant hepatology. First, before I get to Ms. Cryer and hearing about her story, Dr. Dove, can you just explain to our viewers what a transplant hepatologist is?
So a transplant hepatologist is a liver doctor who specializes in taking care of patients who really have what we call end-stage liver disease. They're starting to have liver failure. They don't even just have cirrhosis. Cirrhosis is just the scarring. And you can live with cirrhosis sometimes 10 years with your liver functioning because we have more liver than we need. But when you get to a certain point where you don't have enough normal liver to do all of the functions that a liver has to do, make proteins for you, filter your blood, help you fight infections, then those patients are now going into liver failure. And sometimes the only way to help them is to replace the liver. And that is a liver transplant. Fortunately, that is not the majority of patients who have liver disease. It is not the majority of patients who have fatty liver. It's probably only 20-25% of people who have fatty liver. And any good hepatologist wants to prevent you from ever needing the transplant hepatologist. And that's what I want. The best transplant is no transplant. But once you have liver failure, then the transplant hepatologist steps in, helps you through that process, helps you get evaluated, helps you get on the transplant list, and then takes care of you after transplant to keep that new liver healthy and to keep you healthy and living a normal life.
Thank you. So now we're going to bring in Ms. Cryer. Ms. Cryer doesn't have NASH, but she's had a liver transplant. And so we thought it was really important to bring in her perspective because, again, we are trying to prevent this need for our patients who have fatty liver disease. But it is a possibility in some of our patients when we don't find it early. If we find it early and they aren't able to do the things that Ms. Myers has successfully been able to do. And in fact, 75% of people who have cirrhosis from NASH first learn of their diagnosis of fatty liver at the same time they're learning they have cirrhosis. So there are things we can do at that point, of course, but we really want to change that statistic by finding disease early and reversing it. But for those folks who unfortunately do have progressive liver disease, sometimes their liver fails, as Dr. Dove mentioned, and they need to get a liver transplant. So Ms. Cryer, if you can just talk to us a little bit about your experience of having had a liver transplant, and also as the head of GLI, you have met people from all over the world. It's a global organization, and many people with NASH and many people who have had transplants for NASH. We'd like to hear some of that viewpoint as well.
Absolutely, and thank you for allowing me to sit in this seat and give my moderator seat over to you. It's the only International NASH Day panel that we have done this, and I appreciate the opportunity to talk from my individual experience as a patient, and on behalf of the hundreds of patients that I've personally spoken with and the thousands of patients that we've interacted with who have NASH. Unfortunately, the story that Ms. Myers talks about of is far too common. It's they don't have any pain, have any symptoms, but just all too often when they hear they need a transplant, or even worse, in my view, have liver cancer, that's when they learn that they have had that they have NASH. Perhaps they've heard from a primary care doctor, years before, that their liver enzymes were a little elevated, or they had a little fatty liver, but they weren't told they had fatty liver disease, or that it was something serious or something that they needed to act on. And so unfortunately, they end up in end-stage liver disease, which even though it's 26 years later for me, I still remember, so distinctly. Patients with advanced liver disease, we develop severe complications like ascites, fluid buildup, or varices, where you're bleeding. I've heard talk to patients, and I remember myself vomiting up blood. This is a serious, urgent disease. My kidneys failed, and I had to go on dialysis in the hospital. I lost all clotting factors, and all of a sudden just started the sheets in the bed in the hospital were covered in blood. So when people don't take liver disease seriously, when doctors or policymakers or the public don't take liver disease seriously, I want them to know about the cases that were just like mine, where people were at the brink of death. My parents, my parents were school teachers, and my mother was at my bedside every day when my father was taking care of my little brother, and they told my mother, I had 7 days to live. She prayed so hard that the hospital chaplain started coming to her, and those prayers worked. But unfortunately, they don't work for everybody, and people die every day waiting for a transplant, waiting for the gift of life. I was blessed to receive it, and then to live what is a very healthy life. Liver transplantation is a very successful process, over 90% in the first year and the first 5 years, and I'm making up the prognosis here at 26 years plus. But it is very successful. It is not a cure. I have to take medication for the rest of my life, for the most part, to modulate my immune system, which is sort of a scary thing during a global pandemic for an infectious disease. But, I'm vaccinated, and I'm happy to be so. And I'm now, working and rejoin society. But that time period, those months, with very active, advanced end-stage liver disease, I was in a medical intensive care, surgical intensive care. We could have lost me, and so we need to do something for people very early in the disease. That you can't wait until they get as sick as I was.
Thank you for sharing your story. I didn't even know those details, so wow. Glad that you're here. You're meant to be here. to do all of this great work. I mean, it's really incredible. Thank you. Dr. Dove, I want to kick it back to you for a moment. We kind of briefly talked about, in the case of fatty liver, that it can progress to the point of someone needing a liver transplant. Can you just go over that again for us? How does a fatty liver end up, needing to be a liver that has to be replaced?
So if we go back to the way we were thinking about it in the beginning. So in some people, they just have the fat that's in the liver, but they don't have the liver's not very inflamed. They're sort of living at peace with that fat. We think of it that way. And some people, their liver becomes inflamed by the fat, and then the liver starts to repair, which is its normal mechanism. And if you don't take away the fat, don't get rid of the fat, don't get rid of the inflammation, and the liver continues to repair and repair and repair over years, even decades, it starts making this scar tissue. And then when there's a lot of scar tissue, like we said, all sort of interconnected with sort of normal liver in between, that's cirrhosis. And that process from inflammation to cirrhosis is on average about 20 years. So it takes a long time, and there's a lot of places that you can intervene and try to prevent that process. And then you now have a person who has cirrhosis, but they still have enough normal liver in between to do the job, but then they start losing that. And then when you get down to where you have probably 25% or less of normal liver is when you really start suffering and you start having problems with the liver not doing what it's needing to do. So then, as Ms. Carr mentioned, you start having problems with holding on to a lot of fluid, and that fluid accumulating in your legs and in your stomach. You start having problems with making the proteins that help you clot, so you don't clot as well and you bleed easily. With nosebleeds can be simple, or gum bleeding, but then you can really have serious internal bleeding, like you mentioned, throwing up blood. And then in some people who have cirrhosis, probably related to that liver sort of constantly repairing, it causes the cells in the liver to become really out of, sort of aren't on their normal pattern, and become unusual. And those are the patients who develop cancer. So anyone who has cirrhosis also now has a risk of developing a liver cancer. Most will not, but this is the pathway of the unfortunate group of people who develop cirrhosis and cancer. Again, I just want to emphasize, because I don't want everyone with fatty liver to leave this webinar afraid that they're going to develop cirrhosis and liver cancer. The majority will not. I just want to say that again. But because when I meet someone, I don't know, are you in the 75% of people that's not going to happen to, or are you in that 25% of people who that's going to happen to? As a doctor, I'm treating the worst case scenario. So I'm treating you as if you're that 25%, even though you're not, even if you're not. Because if we attack it and we get rid of the fat, then you don't have the inflammation, then that's not going to happen. And we cannot worry about it. So if we can attack it and prevent it, that's the real takeaway from this. Try the early intervention. If I meet you and this, the horse is out of the barn, as we say, and you already have cirrhosis, then we're fighting. Then we're fighting for a new liver. Then we're fighting for you to have a normal life in that way, and we're there for that too. But I want to sort of emphasize, the majority of people listening to this, you're not in that category, and we want to prevent you from getting to that.
Thank you for driving that home. Prevention is really the key. I like to call myself a primary care hepatologist because my job, I'm not a transplant hepatologist, is to prevent my patients from needing the care of Dr. Dove and her colleagues in transplant hepatology. So I just want to elaborate a little bit, Dr. Dove. What I heard you say is that there's even different degrees of cirrhosis. So some people can have cirrhosis and feel fine and not have symptoms that that Ms. Cryer mentioned earlier. And then other people have, really end-stage liver disease from cirrhosis and need the care of your team. Is that summarized?
That's 100% right.
Yeah. So, Ms. Cryer, I want to hear a little bit about your life since having had a transplant. We are very grateful that your transplant was successful and you have, a new lease on life, so to speak, for lack of a better phrase. But if you can help our viewers understand a little bit more about how you care for your liver, because these things are going to be important for anyone who's had a liver transplant, especially those who've had a transplant for a fatty liver disease.
Absolutely. I think in the first year, I was on a lot of medications. I was given sort of a fishing tackle box of about 17 different medications, immunosuppressants and antivirals and antibiotics and things. And so learning to manage that and to take my medications, on time and in the right order, and some with food, some without food, was difficult at first to learn, but it quickly became a habit, and then over time, fewer and fewer medications. But adjusting to that and learning to listen to my body. And I was very lucky to have a boss who was also a transplant recipient. And so I remember telling him at one point, I'm like, I'm so tired. And he's like, well, go lay down. And I was like, oh, I can do that. And so, I know many transplant recipients don't have, work situations where they can go lay down. And so helping people get back to school and back to work, and finding the financial assistance and support that they need. There is Social Security, disability that are available to people who need that type of support. But I definitely tell people to take the time that you need to heal. And that's why I build organizations like the Global Liver Institute to help get everybody that support, so they can take the time to heal and to re-enter slowly and adjust to their medications. On a daily basis now, 26 years later, and I think for most people after that first year period, firstly the first 2 years, it's about trying to manage the manageable. So all of those, other risk factors that everybody has to deal with, whether it's my heart health or my brain health, my kidney health is very important. Too many liver transplant recipients go on to need kidney transplants, which we know in the African American community, we already have issues with kidney health and higher rates of kidney transplantation. So I don't want to end up on that list. So I drink a lot of water and we monitor my blood pressure very closely. And even though it's not very high, I have a family history of hypertension. So I do take a medication for high blood pressure, and we make sure to keep it very, very, closely controlled. I do, eat a diet that's lower in sugars and those types of simple carbohydrates to make sure that my blood glucose, my blood sugar, even though I don't have diabetes or prediabetes, I don't want to get that and compound that to any situation. And so, I do watch that. I make a great biscuit though, so sometimes it's very hard. I have to say so myself. And so, I remember my father had before he passed congestive heart failure, and so reworking his diet so he could reverse his diabetes and lose weight. And we made a lot of fish dishes. And as soon as he learned that he could put as much Frank hot sauce on everything he wanted, he was in. And so, I've reworked a lot of traditional, Southern dishes to be liver and heart healthy, and because food still has to have some flavor, and I want to enjoy these past 26 years and the next 26. And so that's been fun to rework a lot of recipes, with less butter or less sugar and things like that. And, and then I exercise, it's one of the reasons why, my hair is natural, accelerated by the pandemic. But at some point, you had to choose between your hair and your hips. And so I chose to keep my hips the size that they are, and embrace my curls. And so it really is something that I think about all through the day, every day in the background, as I work, how to stay healthy, what to eat, what to drink, what to take, how to exercise, how to fit it in, how to, reduce stress as much as you can when you're running a global organization, but how to, taking care of myself and the workload and work stream as a patient is as much a priority as any of my other work streams or programs. And so I make everybody from family to, my teammates and staff understand that the number one patient-centered, focus is this patient. And so, if I'm not healthy, we can't do anything that we as an organization want to do. And so, for other transplant recipients and just, people dealing with chronic illnesses, it's not selfish. It's really important to put yourself first and to honor all the things. Sometimes they're overwhelming, but all the things that you need to do to live the best life possible. I do it in honor of my organ donor, certainly, but I also do it for everybody else who depends on me. And so I think all of those things now have become, a habit, but they take a lot of intention and thought and, and negotiation sometimes to be able to do. But it's important for any liver patient, any patient to do.
And that's really, I don't have anything else to add. You've said it all. And I just want to amplify that, getting a new liver doesn't mean that people can go back to old habits, right? Because you have to protect the new liver in the same way, you would need to protect your natural liver. Miss Myers, Miss Cryer was talking a bit about sugar reduction. Can you tell us, how did you lose 16 pounds? What exactly did you focus on in your nutritional journey?
I focus more on low carbs, little to none actually carbs, and cutting out margarine, which was a big factor of my cooking. I just cut some things out that I knew I wasn't supposed to have, fatty foods, and then doing a little more exercising, walking. Yeah, I really don't have many carbs. I tried little to none. That's mainly what I've done.
Yeah, well, it's been highly effective. So thanks for sharing that. It's COVID, it's the pandemic. A lot of people have been putting things off, right? Because quite frankly, you're afraid of getting exposed and getting sick. And so what, Ms. Myers, would you tell the person with fatty liver who says to themselves, I'll just deal with this later, maybe in a year or two when COVID is over, things are kind of back to my old routine? What advice would you give to them?
I would tell them, don't wait. Get ahead of it immediately because you don't want to be a liver recipient. Follow doctor's orders. Cut out those carbs. Exercise more. Cut out the fatty foods, fried foods. Cook more at home. Don't eat out. Get ahead of it as fast as you can because you don't want it to turn for the worse. And because who says that you will be able to get a liver if you need one? Mm-hmm. So I would say follow what the doctor ordered.
Ms. Pryor, what do you say to those folks who are just saying I'll deal with it later, or providers sometimes who want to prioritize other things ahead of dealing with the fatty liver?
So tomorrow is not promised to us. So you need to act today, and that message is for doctors as well as patients. I think that the medical community has done a great job of creating, clinical situations that are COVID safe, being able to, handle COVID patients as well as patients who don't have COVID to be able to receive care safely. I have been, I kept all of my doctor's appointments throughout the pandemic. Some on telehealth, but also I've gone in for infusions when necessary. I had a GI procedure on Tuesday. So like don't miss good colonoscopies or anything like that as well. It was COVID tested before, negative, and so really make sure you have to keep on top of it, because as Dr. Dove said, we don't know who progresses very quickly and who progresses slowly. And so you need to assume that the person in front of you or the person in the mirror may progress really quickly. And so there's an urgency to liver disease that we need to start acting on it and control all the factors. Fatty liver disease is in this context and constellation of other metabolic conditions. So whether you come in from high cholesterol or high blood pressure or obesity or for your fatty liver disease, this is an opportunity to get all of them addressed and under control, because they reinforce each other. Fatty liver disease can lead to increased diabetes, and 70% of people with diabetes have some form of fatty liver disease, and they're driving each other. And so it's really a moment to take a pause right now and get all of those factors under control, so that you can live a long and healthy life. Life expectancy has gone down, and that's a shame. That's on each and every one of us, and we can do something about it to turn that around. But we need to act now.
Yeah, I absolutely agree with that, Dr. Dove. I think you probably have room in your clinic, right, to see people who want to come in. We'll get you in. Is that accurate in your practice?
Oh, 100%.
Yeah, definitely.
Doors are always open for people, and I think that even outside of doctors' practices, education in the community, in every forum, in churches, in beauty shops, now that they're back open, wherever is important. Sometimes in our communities, it's hard to find healthy diet food that's affordable. It's not always easy to find places that you can exercise safely. And so this has to be a neighborhood community initiatives to keep people healthy. And so we are more than happy to lead the charge, but we need a lot of reinforcements. Also because people don't always listen to their doctor, but they might listen to their friend.
And that's why we're here. We're hoping that, your perspectives are going to encourage more people to get at least the conversation started. The last thing I really wanted to get in before we end, without, prompting you and telling you what to say or how to say it. I do often hear that patients, Black patients, and certainly have had that experience myself, get treated a little differently than our majority counterparts when we engage with the health system. And so this question is for you, Ms. Myers. We have a lot of medical students, trainees, young physicians and other providers who are going to be watching this video. And what general advice do you have for them when taking care of patients, especially patients who look like you and me?
My advice would be to genuinely care about the patient. Take time to discuss the diagnosis, to discuss the treatment, to inform the patient. Let them know that it's not the end of the world. It can be turned around by diet and exercise. Just take time to explain thoroughly to the patient. Also, I would suggest, like Dr. Dove stated, put more information in our communities. So advertise it on the bus, advertise it in the church. A lot of times when you're in the elevators, we waiting to get to our floor. We read the signs. Have signs up. Even in our PCPs, put the signs on the wall while we're waiting for the doctor to come in. We always, our eyes wander, and we look and reread things. So my suggestion is to get it out there, get it in the communities, the recreation centers, get it in the churches, anywhere, any place that you can push that information out, put it out, because most of us are not aware of it. So, just to get the information out for our people.
I think those are the best words to end on. I don't even want to follow that. I've been taking notes myself. Things that we can do now to make a difference for folks. And this is really our wrap up of this session. I just really want to thank our panelists and the Global Liver Institute for partnering with ABGH on this very important day of education around the world about a condition that is, 1, preventable, 2, treatable, and 3, reversible if we just get the word out and find folks early. Thank you all for being part of this panel. I also want to extend our thanks to our patient advocates, survivors, caregivers of patients with NAFLD and NASH. And for those watching, please talk to your providers about getting screened if you think you might be at risk, or if your loved one you think might be at risk. I also want to add, talk to your children about this condition. I have 2 little ones, and they already are very well informed about fatty liver disease and know how not to get a fatty liver. So, I'm biased, but it's important conversation to really start with our youngest ones. And to find out more information about our organization, ABGH, you can log on to www.blackandgastro.org. or on social media. You can find us on Twitter and Instagram at Black and Gastro. This recording will be available soon on both our website as well as on the GLI website of globalliver.org. ABGH has a lot planned to continue this conversation in our community. Our network of Black doctors is growing, and we are excited to bring you more. So follow us and stay tuned for our next event. And if you haven't caught the other events that are going on during our International NASH Day programming, it's a fantastic lineup. We are one of many, so please do check them out so that you can really, really immerse yourself in education and educate yourself about this disease. Thank you, everyone.
Thank you.
Thank you.